Today, we are very thankful that you came to hear about a groundbreaking procedure that has taken place here at the Bougainvillea Clinic. As you know, the Bougainvillea Clinic has been doing a number of first type of procedures. So they are the first in doing many of the procedures in the Eastern Caribbean and perhaps in the Caribbean overall. But these are like highly specialized and very beneficial procedures that we are doing here. On Monday of this week, we had the first vertebral disc replacement surgery in the neck performed in the Caribbean other than in Jamaica. Dr. Jeff Liebert, he has another name, but we call him Jeff because that's how he goes. Dr. Jeff Liebert is an expert neurosurgeon trained at the University of the West Indies, trained further in parts of the United States, and has returned to the Caribbean. He is originally from Nevis, so he has a real liking for these smaller islands. So he's come back to the smaller islands to do some of his great work. He's an expert neurosurgeon. And on Monday morning, we had the first ever cervical, that means neck, vertebral, intervertebral disc replacement surgery to be performed in these parts of the world. So I'm going to turn over. I don't know much about the procedure, except from what I read and from what I saw from them. But I know that the patient who underwent this major operation was up and walking later the afternoon and was discharged from hospital, having regained power and sensation in the arm that was affected by these prolapsed discs. So I'm going to turn over at this point to Dr. Jeff Liebert, and he was also assisted by Dr. Kwesi Davis, who is really an ear, nose, and throat surgeon. He himself does a lot of great work, but he assisted Dr. Liebert with this procedure. So I'm going to turn over to them at this point. Thank you.
Dr. Vertebral, thank you for your kind words. And thanks to everybody for coming here today. And it is indeed a pleasure for me to be able to come to the BVI and assist in taking care of patients here. As Dr. Vertebral alluded to, I'm actually from Nevis. I first came to the BVI at the tender age of 14. I'm not quite much older than that now, but that's when I came here first. And since then, you know, I've been able to do quite significant training in Jamaica, in the UK, at Yale in the US, and we've been able to bring those skills back to help our own people here in the Eastern Caribbean. Now, on Monday, as he said, we did what we call a cervical disc replacement, that having done discectomy in that particular patient. And these patients are patients who actually have what we call cervical radiculomyelopathy. And so these are big words, but really all it really means is that these patients have a disc, an abnormal disc in the neck that's compressing the nerves, compressing the spinal cord. And before we get into about the technical aspects of the procedure, if we look at this model, this is essentially a model of the spine. So we can see that here is pretty much the base of the skull, and we have the neck here. And in the neck you have 7 bones, and the spinal cord runs down the middle, so it would be within here, and then you have nerves coming off to the side. Now, in the middle, you have the disc right along here. So the disc are like shock absorbers in a car. So that is essentially our shock absorbers, okay? And the same way like in a car, it will wear down over time. With us, as we grow older, this can happen. Some of the other reasons why patients will have changes in the disc would include things like patients who smoke a lot. Some patients have put on a lot of weight, which can affect that. Sometimes it's occupational. So patients who are using like jackhammers and so forth, for example, that vibration tends to cause changes within the discs that can then prolapse and irritate the spinal cord and the nerves. And again, you have some patients who may have been involved in a motor vehicle accident, they may have whiplash type injuries, and so that affects the discs. Now, most of these patients will come to us and they will say, hey, doc, we have neck pain, this pain is going down my arms, it goes to the fingers, it may be as bad as they may not even be able to move their legs, so they may not be able to walk. So about 2 years ago, actually, we had a patient here who presented to me at the Bougainvillea clinic, and she actually came in a wheelchair and she was unable to walk. And so the only thing that she could do was essentially move the big toe. And when we investigated her, we realized that she had a huge prolapsed disc in the neck. And that is what was the cause of our problem. We subsequently treated her, and now 2 years down the line, she has regained her function. She's able to walk normally, and so she's doing quite well. All right. So these are the kind of stories that we have, and being able to bring this technology here helps quite a bit. Now, some of the other things that we need to discuss would be, how do we investigate these patients? So, for example, most of these patients will have X-rays, which tell us about, how the bony architecture looks. Sometimes what happens is that I'm not sure if you can see clearly, but at the back here you have some joints, and the nerves will be coming off between this layer here. And so some of this bone may overgrow and touch on the nerves, and so that would irritate the nerves. Now, the X-rays would be able to tell us that. It will also be able to tell us whether or not there is any movement of the spine, whether one bone is pushed forwards on the other or not. Okay, and then we tend to do MRIs, and the MRIs now will give us a clear idea as to what is happening with the disc itself, will show us the actual spinal cord, and show us what's happening with the nerves as well. So these are things that we do generally. Now, most patients do not require surgery. So you would have up to about 90% of patients who don't require surgery. So here at Bougainvillea, we are very selective in who we do surgeries on. So we don't just do surgeries because we can do it. All right, so we essentially make sure that we choose our patients carefully, and those patients we know that they ultimately will benefit and tend to do better. So in terms of treatment aspects, we do, some patients will have physiotherapy. We ask patients to, their lifestyle changes that they have to look at, for example, within the neck. Recently, we've been seeing a lot of younger patients, and this, we think, we're still studying it, but we think that it may be related to things like cell phone use, so everybody's kind of looking down and pressing, and so all of that is affecting the neck as opposed to being sort of more neutral position on the neck. And so, for example, a lot of my patients, I say to them, hey, when you're sitting on the computer, you need to be looking straight at the computer. All right, so the ergonomics within your workspace is also important. So there are a lot of different aspects here that we look at. Patients who smoke tend to have a lot more of these illnesses. So again, we tell patients, hey, this is something that you probably should not be doing. And not only does it help the neck, it also helps in terms of cardiovascular disease and other neurovascular diseases as well. So those are some of the important aspects that we look at. So more specifically now to what we did on Monday, what that was is a disc replacement. So having taken out the disc from here, remove that, okay, we have to put something back into space. Now, in the past, what we used to do is something called fusion. So what we would do is that we would remove the disc. Now, I have a picture here that will show you what it actually looks like. So if we look at this picture, then this is an X-ray of the neck. So top here is the base of the skull, and these are the vertebrae coming down here. Now this patient particular patient had what we call a fusion. So they had something bone put in the middle here, and then they had this huge plate on the front. Okay. Now, the problem with this patient, this is a patient I saw 10 years after this procedure, and she developed what we call adjacent segment disease. And so at the top here and below, she then had the disc at that level broke down. And it breaks down because when you fuse the spine, here does not move, the other areas above move more, and so they're clearly doing more work, and so that now causes the disc to break down. So that is what happened with this patient. And so what I did here is that we did a disc replacement at the top and below this particular construct. Okay, so you can see here, this is a disc above, and below the construct is where we did that disc replacement. Now, if we did not do this for this particular patient, what would happen is that essentially a whole neck would be fused, and so she would not be able to bend forwards like that, bend backwards fully, lateral bending like this, or turning the head like that. So those are the advantages in terms of having to do that procedure. So so what we did was a disc replacement for that patient on Monday, and by doing disc replacements, there are clear advantages to doing that. So one, what we want to do is to maintain the patient's motion. So in the past, for example, way back when they started doing hip joint replacements in orthopedic, for example, before they did that, they used to fuse a hip. Now, I'm sure most people would prefer to be able to walk properly, moving their hip, than to have their hip fused. And so the technology sort of developed based on the same sort of principles that you would have had with the joint replacements in orthopedic. And of course, this now has translated to being able to be used in the neck itself. So this maintains motion, so that is one of the key aspects, because we all want to be able to continue to move our necks, to be able to bend forward to normal, and that is why we have the disc, because that is the motion segment allows us to be able to function essentially in a normal way. Now, one of the challenges with fusing the spine, which is what was done in the past, is that once you fuse the spine, you get the adjacent segment disease, and so patients then subsequently end up needing future operations. And actually, in patients that we fuse, they are 4 times at least more likely to need a second operation as opposed to patients who we're doing a disc replacement for. And that is significant for the patients, because nobody wants to be undergoing several operations. All right. Patients are now able to be up and about a lot quicker using these operations. So the techniques and the technologies that we have allow us to make smaller incisions. We're doing less dissection or movement within the neck, and so these patients are able to be up and about and out of hospital a lot quicker. So we see this patient that we did on Monday, for example, he was out of hospital within 24 hours of doing the surgery. And in addition to that, he was weak initially in his upper limbs, and he actually had normal power by the time he was being discharged from hospital. So that was quite we're quite happy for that. We thank God that everything went well. I'm a very religious person, so I believe that God is the one who guides me, and He always does that. So but we're very happy, and we're happy that we're able to bring that here to the BVI. The other thing is that in addition to this, we're able to essentially create savings for patients, savings for governments, savings for insurance companies, etc. Because you're not doing repeat procedures, and in addition to that, patients are also back out in the workforce a lot. I'm really happy in terms of the support that we've gotten from the National Health Insurance. They have actually been quite helpful in helping us to get this sort of technology to the people of the BVI, and I'm quite happy for that. Other thing that I'm not even sure if Dr. Vanderpool knows, but we've been getting patients here from Anguilla, which is where he's from. Patients coming from St. Martin, so a few of them have been coming here to see us, and so you can see here that in BVI we actually are doing our own medical tourism right here, so which is one of the key things for us as well. So, you know, we're quite happy in terms of how things are going. I'm happy that we're able to bring this technology here, and I do believe that, you know, this will essentially help us to continue to build neurosurgery, build the care of our patients here. And Dr. Vertebral as well, thanks a lot as well to him, because he has also spearheaded us getting, you know, I'm always harassing him about equipment and saying, hey, listen, we need to have the appropriate things here so that we can give the people the best care that is out there. So what we are offering you is the care that you would get in any first world country, okay? And that is what we want to do. For me, I treat patients the way I want to be treated, or the way I want my family to be treated. So life is very simple. And so sometimes he probably thinks I'm a bit pig-headed, but you know, I really want to make sure that we have the best for our people. Okay? And you know, we will continue to build. I'm here for the long term. I'm committed to building, you know, the best neurological care within this part of the region. And so we're here for the long term. We're here to help our patients. That is why we do what we do. And you know, we will give our best 100% of the time. Okay, so if we have any, this patient essentially had presented to us with neck pain. He had an arm pain as well as associated weakness, and this had been ongoing for quite some time. And he also had trial of conservative measures, so he would have had the physiotherapy, painkillers, all of these things, and those were just not working. His investigations had showed that he had a prolapsed disc, well, more than one. He had several prolapsed discs in the neck that were actually causing the system. And in addition to that, he was at risk because of the type of work that he did for an injury. And if he got injured on the job, he probably would end up being paralyzed. So he was taken to the operating room, and you know, we did a proper decompression for him. You know, in terms of time, Esther, I pretty much like to say to patients, it takes as long as it takes to get it done properly. So I don't actually look at the clock. I'm not sitting and trying to get it done as fast as I can because I need to move on to the next patient. The key for me is to make sure that I get it done properly. And you know, so it takes different times in different patients because everybody's different, and you know, there's not a sort of one shoe fitting all. Okay, so it takes different amounts of time. So it might range from 2 hours to 6 hours. So you know, but I will stay there and get the job done no matter how long it takes. Okay. One of the other aspects which I didn't mention about this particular disc that we use as well as we talk about footprints is that one of the beauty of it is that we're able to sort of individualize the size of it for each patient because we have several different sizes that we can choose from. So during the surgery, we're able to essentially measure and look at how it fits into this particular patient and use the appropriate size for that particular patient. So everything is sort of individualized for each patient. So you're essentially regaining the normal height that you had before and the normal function that you would have had before. All right? What else?
Yes, give it to JTV News. Thank you. Could you, for explanation's sake, you said you saw a patient some 2 years ago,
yes,
probably with a similar
yes,
case. That person was treated and recovered nicely.
yes.
Compare for me the technology used then as opposed to the one that you used on Monday,
Right.
and which is the preferable and why the differences?
Right, so that's an excellent question as well. And there are different technologies used for different things. And so that particular patient, for example, did not have a disc replacement, and there are specific indications that we use for both disc replacement and what she had, which was fusion. And fusion is still a good operation, and that was actually, you know, that was the gold standard for years. but now we have a disc replacement that affords us additional advantages. But as regards to that specific patient, she had what we call myelomalacia in her spinal cord. So there were changes within the spinal cord. So her spinal cord itself was actually showed some amount of injury. And for those particular patients, we want to limit the amount of movement that you had. So what she had done was what we call a standalone fusion. So again, that is actually newer technology than what obtained before, and it is excellent technology. So before, what would have been done was this plate. Okay, for that particular patient, what we did was I used this device. All right, and again, this particular device with this standalone fusion, that allowed me to make a smaller incision, do less dissection. All right, this particular one does what we call compression, so the screws pull all the bones together, and that now is able to help the bones to fuse a lot quicker. In addition to that, there are what we call zero profile devices. So both the disc replacement and the one that I used 2 years ago in that patient. Zero profile means that it lies within the spine itself. So this plate is above the bone. So the plate that I showed you before would sit on here, like that. Okay? And then you have screws going into the bones above and below. This technology, the disc, as well as the standalone technology that I use for fusion, actually sits within the space. So all of the normal tissues in front lie back in their normal position. And that's important because we're doing less dissection. Patients now would no longer be complaining, hey doc, I feel a big lump in the back of my throat and so on. So that actually, the patient satisfaction is a lot higher.
Okay, 2 more questions
Sure.
for me. Next to you is my friend, forgive me for forgetting your name at
Dr.
this
Davis,
moment,
yes.
Dr. Davis. Would have been wondering why the choice of Dr. Davis to be partnering with you, but then when I said in my head, ear, nose, and throat,
Yes.
and then the comparison came alive. Am I correct in my assessment?
Yes, actually, my first job out of medical school, Dr. Jeff was my direct supervisor. And I can tell you it was a difficult job orienting myself to practice of medicine. And he excelled then at supervising me. And essentially every superhero needs a sidekick. I have made myself do that. The neck is an area, because part of the designation in terms of the type of surgery I do is head and neck surgery. So the neck is an area to which I'm native. And so it seemed to fit. We have a working experience with each other. We've done cases together in Jamaica, even subsequent to my early orientation into medicine. And so we've just continued that relationship.
Okay, and my final question to
Sure.
you, you mentioned the prevalence of these conditions now surfacing among youths, and you alluded to one thing that we know for sure can be a factor indeed, new age technology, the phones and the computer. Right. I remember not so long ago someone said to me, hey girl, you need to put that down a little bit, right, because very soon we'll have a nation of people like this. Right. Explain for us some more the significance and the importance of paying attention to this particular issue as it relates to us with new age technology.
Yes, and technology is good, and we do embrace the technology, but at the same time, we definitely have to still think about ways of protecting our bodies. And so, the things that I would have said before in terms of making sure that you're not always flexing the neck when you do these, if you use headphones and so forth, so that you can you're better able to function without necessarily bending your head and so forth. Within the workplace, making sure that you're trying to keep the neck neutral, and these are things that will help you. Exercise as well is quite important, because what happens then is that you're able to develop the musculature. And remember that even within the neck, your muscles play an important role as well in maintaining the health of the neck. So exercise as well is quite important. Making sure that you are drinking adequate amount of fluids, staying hydrated. Actually, one of the things I didn't mention is that the middle part of the disc, the native disc, actually has quite a bit of fluid within it, and that is what actually maintains some of the height of it and the health of the disc. So staying hydrated will help the disc, and it generally is a healthy practice.
Let me a quick follow on to that one. You mentioned, in order to put down this a little bit, the use of earphones.
Right.
Talk to us a little bit about some complications or precautions that we need to take also with that, you being an ear, nose, and throat specialist.
Right. The thing about using earphones and using it often is that sometimes we get sort of used to high volumes and we don't modulate the exposure we have to these high volumes. So the exposure becomes hours a day and hours a day. And the problem is that we have a delicate organ in our inner ear that is supposed to turn all these mechanical waves into nerve impulses. And that organ gets damaged at a very high rate when you're exposed to constant loud sounds. So that's part of the problem of technology in general, as we're alluding to. I want to get back to the spine though by talking about an anecdotal patient I saw about 4 weeks ago. Elderly gentleman, and he actually had seen Dr. Liber, but there was some kerfuffle with his health insurance provider at the time. So when we have award-winning technology right here at home, and it's a point I particularly want to drive home.
If you say can be reversed?
There and so the idea is that we do need to get it right the first time.
Well, in fusion, if you fuse the spine, essentially it becomes one block of bone. So once you fuse it, everything's bone grows through it, and you get one block of bone. So whereas you would have been able to move everything, now all of this essentially becomes one unit. It no longer moves, and then the rest of the movement occurs at the top. Okay, so that is the challenge. So if we needed to do further operations, you essentially have to either drill all of that bone out, or we have to essentially go to the back now and try to address the problem from the back. Okay, which again has its own attendant problems. Right.
You mentioned, that Javon Wilson, 284 Media, you mentioned that 95% of your patients may not require surgery.
Right.
How are you able to extinguish as a specialist who may require surgery?
Right, so about 90% generally of patients do not require spinal surgery. The patients who will require surgery are patients who are having persistent symptoms. They may be having significant pain going down the arms. They may be having weakness associated with that. There are a lot of times there's evidence of spinal cord compression, which we can elicit when we examine the patients. And then of course we're going to have investigations, the MRI. Sometimes we do what we call nerve conduction studies, which are special electrical tests that are used to tell us how much the nerves and the spinal cord is being compressed.
Which are available here, by the way.
And then the majority of patients who we would have done surgeries on, they've gone through a trial of doing non-operative things before we actually get to that point. So we know that these other things are not working, okay? And these patients have the actual indications for doing surgeries, and so those are the ones that we're doing. And that is the smaller percentage of patients. So majority of patients will respond to lifestyle changes, medications, physiotherapy, losing weight, healthy stuff that we recommend to everybody. All right.
Based on your experience and of course interaction not only with the BVI public but the region, how prevalent of an issue would you say this is?
It is quite common. I think that in different islands, because I actually practice in different islands, so I'm actually seeing a difference in some of the islands. I'm not sure what exact reasons are, and over my practice I will study these because we are scientists as well. So we will study and try to figure out what are the reasons why we are seeing differences in different populations. So some populations I'm seeing more brain tumors because I do both brain and spine surgery. And then in other patients I'm seeing more spine related. In some regions I'm seeing more problems in the neck. In others I'm seeing more in the lower back. So we're still sort of trying to determine why this is so in each of these populations. All right, so it's something that's ongoing, and probably at another conference, press conference, we will be able to discuss that some more.
Thank you.
Final question for me. What assurances can you give persons who are a bit skeptical about coming here? Because we often think going out there is always better than what is right in front of us.
Right.
What assurances can you give persons locally?
Right. So I think that it's really a culture, and a lot of us in the Caribbean and as a people, we always look north and think that everything that is north of us is better than what we have at home. All right, and we always say, when I was growing up, they always used to get a little saying that says the grass always looks green on the other side. All right, but it's not always so. We are well trained. This is what we do. It takes several years to do neurosurgery and what we do. For me, my patients come first. I'm well trained, like most neurosurgeons are, and we essentially are making sure that we bring the right technology to the people. We have the technology available here. I have, as I said earlier in the press conference, I've essentially waited until we had the right technology here before I can do this here. So I'm very sort of obsessive compulsive about things like that. So we had to make sure that we had all the right tools available here before we would actually proceed to do that. So I know that, and I'm quite confident. I don't do things where I'm not comfortable doing it. So because at the end of the day, the most important thing to me is protecting my patients and making sure that my procedures are safe. So here in the BVI, we've been able to get the technology, get all the equipment that we need to the level that we can safely do these surgeries, which is the most important thing. And then we have the skill available. We have this technology essentially is something that the technology that we're using, we've put in, and you can see in the handout that you have worldwide over 125,000 of these have been put in. And this particular technology we use is actually one of the most studied and rigorously tested worldwide, and it was actually one of the first technologies to be FDA approved. So what we have here is something that is on par to anywhere else in the world. Okay, and
at time supersedes
that. Yes. So that hopefully is a long way of answering the short question.
One last one. Many times in a procedure like these, we need to put the person to sleep. Am I correct?
Well,
if
all
this
of
was
these
the case.
for the patients.
So
yes.
tell me about the anesthesiologist.
Yeah, so the anesthesiologist who did our surgery with us is Dr. Craig Stout. Dr. Stout and I actually did quite some work together in Jamaica, and he is an excellent anesthetist. One of the key things that we pay attention to is when we're doing these procedures is keeping what we call the neck in line, so that when he's putting the patient to sleep, we're not moving the neck too much, and he pays special attention to things like that. So we know that the patients are always being kept safe. In addition to that, here at Bougainvillea, I think that I just want to publicly thank all the staff, the operating staff, all our nurses, the auxiliary staff. Everybody here has been extremely helpful in making sure that we're taking and getting the best care to our people here.
I'd like to add just a quick word about Dr. Stout. I too worked with him before in Jamaica, and essentially our training was together. With ENT, it probably is the most challenging type of surgical specialty you can do when it comes to anesthesia, because we always have stuff in the airway, in the corridor, that our anesthetist is going to use. And I can state categorically that I have not worked ever with a more skillful anesthetist. That's important because it allows me the comfort of sitting in my office and telling my patients they will be all right. Don't worry.
Krishna Chefivia Beacon. Just on a related note, I assume with this surgery there are risks as there are in any surgery. Can you maybe talk a little bit about those and how you might sort of mitigate against them?
All right. So with any surgery that you do, there are risks associated with it. So we're looking at risk of bleeding. The thing about bleeding is that most of these patients will have minimal blood loss because of the techniques that we're using, which are minimally invasive and less invasive techniques. So there's actually less bleeding. Most patients would not require a transfusion. There's risk of infections, but patients are given antibiotics to decrease that risk. So everything we're doing is geared at decreasing the risk of complication avoidance. We use small instruments, special instruments that do not compress the spinal cord, and we're using magnification. So we have microscopes that we use that would make a strand of hair look as big as your finger. So all of these are things that we're using to mitigate complications. Another question?
Please, Dr. Vertebral. Most people are thinking of the neck and you're doing neurosurgery. I mean, the fear is that they could get paralyzed.
Yes.
What is the likelihood, well, not likelihood necessarily, but what are the chances? What do you do to prevent this potentially very serious complication?
Yeah, so this is an excellent question again, Dr. Danful. And of course, as I said, when we do these surgeries, well, one, the training starts pretty early. So in my training, for example, I did 15 years of training before I actually went on my own. Okay, so you're from very early. You're learning to do these things. You're learning what you need to do or not do to ensure that you don't get these complications. And it starts pretty early, from putting the patient to sleep. Okay, making sure that we're keeping the head straight, that we're not moving the head around too much. So that's why we have important that we have our anesthetists. The microscopes that we use, all right? So we have magnification. We're using instruments that are small, like some of them are like a millimeter thick. Okay, so you can see how tiny that is, and those are the things that we're using around the spinal cord. Okay, and all of these are techniques that we're going to be using now to not put too much pressure on the spinal cord, so that we can decrease the risk of having an injury to the spinal cord.
How do you steady your hand?
Well, that's probably a God-given gift, but it's something we work on as well.
The concept is that we treat neural tissue, we make it sacrosanct, treat it like a newborn baby, and take very good care of it. And that's the idea, that's the mantra.
Right, we respect the spinal cord.
Thank you so much.
All right, thanks everybody.
Well, I would like to thank Dr. Leibel again for this excellent work he's done. I was very impressed. The patient is extremely happy. He got up the same afternoon, and the next day he was discharged, walking up and down. He started to show that he could, his arms, which were quite weak before, I think it was one arm or both arms?
Well, both were weak, but one was worse than the other.
Okay, and he was able to show off how quickly that patient is gone home. We have one other here, but we won't put him on the stand right now. So I want to thank him. Thank Dr. Crazy Davis again. He is an ear, nose, and throat surgeon, but the other name for it is a head and neck surgeon. So you see, he's a head and neck surgeon. It fits right in with the neck surgery that was performed a couple of days ago. And I've been a doctor for many, many years. I graduated in 1978, so I've been around 41 years as a doctor. And but I am just completely impressed by the advances that we are seeing taking place here by these expert doctors that come from around the Caribbean in general. And so we, in our own Caribbean nation, are being able to give very high quality service to our Caribbean brothers and sisters, and to anybody as a matter of fact. Okay? So I want to thank you again, Doctor, once again. And thank everyone for coming. And there'll be more to come. Okay? Not only from the neurosurgeon, but there are other major developments in the pipeline that will again be the first in the Caribbean. Not but in this part of the Caribbean. Thank you.